Qualified medical practitioners in South Africa are said to receive some of the best medical training available and are generally regarded highly anywhere in the world. Once qualified, these doctors choose to either work in the public or private sector. A fair number of them choose not to specialize in any field and practice general medicine in both the public and private sectors. They are then often referred to as general practitioners or GPs. Now, there are notable differences in their practice between the public and private sectors. On the other hand, South Africa and the rest of the developing world is facing a quadruple burden of disease, with non-communicable diseases or chronic diseases of lifestyle such as diabetes, high blood pressure, heart disease being on the increase. We know that for any society, primary health care forms the cornerstone of any healthcare delivery strategy. But what is primary health care, and what role do general medical practitioners play in its delivery? Well, stay tuned, because these are the questions we'll try and answer in today's show. We have a panel of experts from the National Department of Health in South Africa, the medical aid industry, and a general practitioner to unpack the subject of the role of the GP in primary health care. So sit back, relax, and learn from this exciting show ahead. Interact with us again on Facebook, SABC Health Talk, Twitter at SABC Health Talk, email address healthtalk@sabc.co.za. I'm Dr. Sello Mutaung, and this is Health Talk.
South Africa's healthcare system has been based on treating rather than preventing sicknesses. One of the ways the Department of Health hopes to change this is by introducing community health workers who will visit people in their homes to pick up basic health problems early.
It is meant to make sure that everybody has access to healthcare, irrespective of social status. In other words, quality healthcare accessible to everybody.
The Kenneth Kaunda district in the Northwest has benefited greatly from the introduction of community health workers.
Some of the criteria were, well, for particularly talking about Dr. Kenneth Kaunda district, one of the criteria was that we have the least number of clinics in this district, and we have a huge component of private health sector in this district.
Community health workers have helped to take the pressure off overcrowded clinics and hospitals by offering basic health care at home. Each community health worker is allocated a certain number of houses in the area.
Respectively, go register the household. Go itse gore mo 26 re na le how many household. Ha re fetsa go itse gore re na le how many household, e be re register all the households re na le tsona. Afterwards, baba share the household tseo go ya ka number e ba neng ba le mo go yona e re leng yona. So is whereby ba bangwe ba ke ba kry le bo 300 household, ba bangwe ba kry le bo 302 household.
We are trying to re-engineer it in such a way that maximum number of people see people, community health workers and their team leader going and working on prevention and early detection at home in the communities. They go and screen the patients. If there's an early detection of disease, they refer them to the clinic or CHC or hospital, whatever will be the most relevant place to refer. And they will try and prevent some of the diseases that can be prevented.
Rona re ya ko matlong re lo checka batho hore ba nwele dipidisi tsa bone ba tswa bo dipetlele a jere ka tlhantse re ba checkela ba etsa ntho re reng ba ietse.
In their day-to-day work, health workers deal with a variety of life-threatening illnesses and diseases.
Ke dila le HIV and AIDS, TB, high blood, sukiri, bo mentale, bo epilepsy.
Community health workers have been trained to pay particular attention to children under the age of 5, babies, and pregnant women. The screening and early detection of illnesses is vitally important in their work.
So re check gore o tla clinicing early, o buka early, go prevent the complications tse o kry dile teng mo baimaneng. Re ba gakolele go tla clinicing every time.
Because most workers come from the communities they serve, it is easy for the patients to open up about their illnesses. And in return, the health worker feels that she's part of the family and that the results give her a sense of pride in the work that she's doing.
Nna ke motlotlo thata because of which means mmereko ke felelang. Lelapa le ke lelapa la ntlha le ke thomang ka lona, which means go tla tla le leng le le fetisang mo. Ke tlamile hela le matsapa ke a tseile mo. Ke tlamile le mo lone ko lelapeng le ke tse matsapa ao. Ke se ka fella mo lelapeng le hela.
Thanks to these community health workers taking care in people's homes, South Africa is set for a healthier future.
We are introducing a preventative healthcare system within a curative environment. The two can go together until ultimately prevention becomes better than cure.
There's immense work to be done, and everybody should collectively ensure that we make NHI a success.
Prevention is certainly better than cure. Now, before attempting to tackle the issue of the role of the GP, it is important that we firstly understand what primary health care is and how important it is in maintaining health and or combating disease. Now, to help us understand this further, we have a special guest in our midst today, Mr. Rampelani Murawani, who's Chief Director, District Health Services within the National Department of Health in South Africa. Welcome to Health Talk.
Okay. Thanks very much, Dr. Mdaun, for having me, and I want to greet the viewers at home.
Right.
Yes.
Now, we've seen an interesting insert, tackling one very important aspect, delivery of health care at the doorstep, if you like. Now, in my introduction, I mentioned that, primary health care forms the cornerstone of any healthcare, strategy. Now, what is, perhaps in simple terms, what is primary health care?
In the simplest way of defining primary health care, it is that basket of services that are delivered at the level lowest, closest to the community.
Right.
It will start at the community level, as we have explained that in the insert that was shown.
Yeah.
Then it will then go to the clinics. So this is where the bulk of primary health care services are delivered.
Right.
Closest to where people live, closest to where people stay, closest to where people play, closest to where people work, so that people access services without any difficulties of traveling long distances, having to pay money to access services. So that's the primary health care in the simplest way of defining it.
Okay. There was mention there about preventative services within in a curative environment. Please just unpack that for us.
You see, the old adage of prevention is better than cure comes very, very clear when you talk about primary health care.
Right.
Preventative services, the people that are working at the community level, the community health care workers, go to the households to firstly educate people about what you call health-seeking behavior, helping people about basic home-based care. What is it that people can do to care for themselves? What is it that people need to do when they first, for an example, experience an itch in the body? What do they do before seeking technical, clinical, advanced care? What is it that people... So we need to prevent disease at that level. So that when people go to the health facilities, it is clear that this condition that they're suffering from cannot be managed at the home level, at the community level. Then they can then go to that next level. If you go to our facilities, most of the people are suffering from the problems that can be sorted out at home if they were to take care of themselves. I mean, food security issues come there. Issues of just cleanliness of households, how people handle food preparation comes there. So people are taught about those things. Washing hands before handling food. Those things come at that level. So it is at that level that we emphasize prevention. So only when we can't succeed with prevention or the condition is actually getting slightly bad, then can they go to the next level of care.
Yeah. Which is your clinic?
Which is a clinic or a community health center if that's the nearest one to them.
Okay, perhaps, I mean, this forms the basis, for our next question then, to say, what are the components, of primary healthcare, or simply put, how are healthcare services structured in South Africa? Perhaps related to that, I mean, a year or two ago, we heard about re-engineering of primary healthcare services. So just take us through how primary healthcare services are structured in South Africa and where we are with re-engineering of these health services.
I think it's this way. The first level of the health arrangement is at the community level, which is community-based health services,
right,
which is where you then find this prevention, promotion,
right,
rehabilitation, home visits, home care, visit to households. This is where it is.
Right.
The next level is then the clinics,
right,
which is the clinics will then range from those that are rendering services over 5 days in a week, 7 days in a week, those that are rendering 24 hours in some areas. And then from there, you then go to the community health centers, right, which are bigger than clinics.
Yeah. So who mans the clinic? Let's just focus on the
clinic.
On the clinics for now, yeah?
The clinic is manned by a professional nurse,
right,
who's preferably qualified in primary healthcare training,
okay,
which is more preventative.
So the so-called primary healthcare nurse?
Primary healthcare nurse,
right,
who do the basic assessments, diagnosis, and treatment training, right, at various institutions in our country.
Right.
So it's meant by those people. And it's supported by other general nurses. There could be basic general with midwifery only or with community nursing only. And they're supported by enrolled nurses or what people would call staff nurses.
Yeah.
Then there are enrolled nursing assistants and, Then we could have counselors there, you can have health promoters in the clinic. It's supported again on regular basis by visiting environmental health practitioner, what people would call a health inspector.
Yeah.
We could be supported by a team of oral health team, oral hygienist, dental therapist, and dentist. And the school health nurses could also visit there. So it is how the clinic is actually staffed.
All right. So no doctor at that point?
A doctor could come, a visiting doctor could come on certain days.
Right.
Because the essence of primary health care is that it must be nurse-driven.
Right.
But we know that our people have come to associate health with their doctor.
Right. Okay.
That is why we then took an initiative of going to another approach of contacting GPs, but I think I'll come to that later.
Okay.
But there could be a visiting doctor
right,
in the clinic, not really a resident doctor in the clinic.
Okay. Then let's talk about the so-called district health centers, as it were. What is there? Because we hear that, in a district, that sort of environment, you'll have a family practitioner, you'll have a pediatrician, you'll have a gynecologist, and so on. Just take us through that concept.
The community health centers are your larger facilities than the clinics.
Right.
They have resident doctors that are there every day to see patients that are referred to them by nurses. Once nurses diagnose or assess and they realize that this condition is above their scope of practice or needs further management by a doctor, they then refer to the doctor.
Okay.
And
So I mean, nurses working at the basic, health clinics, as it were, referring to a heart clinic.
That could be that. They could refer from a clinic to the health center.
Yeah.
But even in the health center, because it would be like almost a smaller hospital, as it were. Okay. You still have a group of nurses that are working there.
Yeah.
Your midwives, your primary healthcare nurses and stuff.
Yeah.
But the first point of contact for a patient becomes a nurse.
Yeah.
A nurse makes an assessment, basic assessment. Once they, in their determination, think that this condition requires an attention of a doctor, they then, in the same facility, refer this patient to the doctor for the doctor to see.
Okay.
Because
we're running out of time in this segment, but before we stop our discussion, I'd like us to just focus on that aspect of the family physician that you say is in that facility.
Okay.
What type of doctor is he? What sort of training would he have had?
At that level, we would preferably employ a general practitioner,
Okay.
A doctor qualified from medical school, obviously having gone through the ranks of community doctor, community service and stuff, but a doctor generally.
Right.
But the next category that we prefer, it's a family physician, would be at that level.
Okay.
Because you don't want to create more specialization at that level. Right. So you preferably need to have a GP would be suitable to work at that level, and a family physician will be able to work at that level. But of course, they need to be supported by other specialists, either on visiting basis, like your gynecologist will then be able to come, pediatricians will also be able to come, mental health and psychiatrists will be able to come also. Yeah.
Last question. Is this the ideal, or is it what's happening on the ground currently? Where are we now?
It's happening, but it would vary. As you know, South Africa, I mean, it's unequal. Yeah. It would vary in other areas. I mean, if you go to other provinces that are well-to-do, are richer, abundance of resources, you'd have this arrangement. Yeah. If you go to more rural and deprived provinces, you may not have this arrangement. Yeah. In other provinces, you may have a full complement, even of specialized nurses. You may have full complement. Right. In a province, you may not have. Okay. So it's something that is happening. Our desire is obviously to grow it, to make sure that every facility has got that coverage, but they should know.
I think it's on that point that we'll just break it there for a while. After the break now, we'll learn all about what the general practitioner is, what he does. Please stay with us.
My people, we are getting there, and thanks to you, Pati is set to become our country's 12th official language. Here's today's word. Substitute, replacing a drinking buddy with somebody more fun. It's more like it.
Hey you, smooth supporter, get a bottle of Jameson for only $244.99 and help make Party South Africa's 12th official language. Tops at Spa. Shake things up.
Technology is all around us and is improving lives across Africa, like how young Nigerians are connecting to the internet. There are doctors finding new ways to save lives in Cameroon, and the South African public transport system that is now getting Wi-Fi. We have gadgets, apps and loads more, some of which play a big role in Africa's growth. A huge part of this African growth is technological innovation. To find out a bit more about social media and technology news from here in Africa and abroad, join me, Siphumelele Zondi, every Sunday at 7:30 p.m. on SABC News.
Welcome to AM News here on SABC News Channel 404.
The people who also should be concerned are the people who voted for people of that ilk.
South Africa is indeed a unique country. And South Africa has a democracy that is very exceptional.
If people want to change the rules, do it properly, do it within the context of the Rules Committee within Parliament. And when you shout, it doesn't mean people are listening to you.
But there is a point of authority that must always prevail.
The ANC is very determined. We will not allow South Africa's Parliament to be dragged down into the mud. And we will defend the Constitution and Parliament.
I think our country is really being torn to pieces. And I think that the struggle for liberation didn't take place for people to play the fool like this in our country.
That's AM News, daily at 10 a.m. on SABC News.
Welcome back. Now, what exactly is a GP? How different is he or she from a family practitioner, a family physician, a medical officer, family medicine specialist? Well, let's learn more from our special guests. We're joined by Dr. Elijah Nkosi, who's a general practitioner himself and is CEO of SPNet, which is a group of doctors. Perhaps he'll tell more. He'll tell us more about that himself in a while. Welcome to Health Talk, Elijah.
Hi. Good morning, and to you and to the viewers at home.
All right. And next we have Dr. Mike Marshall. Dr. Marshall is General Manager, Provider Contracting just for short, because his title is quite long, from Met Scheme. Welcome to Health Talk.
Thank you, Sela. Morning.
All right. Perhaps I know that you're CEO of SPNet, and you also represent an organization called the IPA Foundation. Please tell us about those two organizations.
Yeah. We have what we call IPAs, and IPAs is formed by family practitioners or general practitioners. Maybe just to clarify the difference between a family physician and a family practitioner so that there is no confusion.
We'll get to that just now. Just the IPA Foundation and the SPNet very quickly,
SPNet, it's SMDP provider network. It's a group of doctors who are practicing in previously disadvantaged areas.
Right.
So what has happened now, doctors have come together from the various IPAs and formed a national network, which is called SPNet. And then there's also networks in other areas, like around the coastal areas. One would have SABC in Cape Town, one has CPC, Qualicare. So all of these networks have come together to form a national body, which is known as the IPA Foundation of SA.
Right.
So
But yourself, you are a general practitioner?
Yeah.
Or
I am, well, what is commonly called a general practitioner, but would rather be called family practitioner.
Right.
Simply because we treat families.
All right. Yeah. Okay. And then take us through the differences then between a family practitioner and a family physician.
Yeah. You know, a family physician would be someone who's done the basic medical degree, MPCHB,
right,
and then specializes in family medicine.
Right.
And he becomes a specialist. And that person is then called a family physician.
Right.
In our case, we have the basic degree and other qualifications, but not qualifications towards a higher degree.
Right. Okay. Okay, maybe let me ask Dr. Marshall, in terms of the numbers, I mean, you know, you deal with a lot of family practitioners in the medical aid industry. What sort of numbers are we talking about?
Yes, so the claims that we get from family practitioners sort of indicate to us there's probably about 6,000 family practitioners, I would say, in active practice. You know, there are many that perhaps are part-time, and that probably between 5,500 and 6,000 in full-time active practice spread across the country, and I guess that's distributed around a membership of about 9 million. So if you sort of look at those numbers, it's sort of about 1,500 lives per family practitioner. So it's actually not a bad distribution. I think it's
right.
It's an important resource that we should be using.
Yeah, but clearly there's differences. I mean, in terms of, I mean, it creates a picture that we have adequate number of doctors, whereas we really are talking about the private sector where the members are fewer.
Yes.
But the situation is obviously different when you look at the entire country.
Yeah.
Because, you know, the picture might be different. Your comment?
Yeah, I mean, our network, I mean, the IPA Foundation has about 5,000 members or so who are part of the network.
Yeah.
And in terms of distribution, we are national. Yeah. It's in all the provinces.
Is it? Yeah. Maybe let's talk about distribution. I mean, if you look at urban areas versus rural areas, there's often this and justifiable concern that you know, doctors tend to concentrate in urban areas more than, you know, rural areas. Your comment?
Yeah, no, that is true. You know, if you go to an area like Soweto, I mean, Soweto has more than 100 family practitioners practicing, you know, in that very small area. But if you go to areas, outlying areas, like Zanin, Venda, I mean, in that, as a network, we do have doctors in those areas, so we tend to visit them. You see that, you know, they're treating quite a number of patients compared to the number of patients that we see in urban areas.
Okay. Let's get into now a family practitioner, typical family practitioner, and look at the scope of practice. First of all, what does it take for a doctor, a newly qualified doctor, to run a private medical practice?
That's what it would take is someone who's qualified, done community service, and in actual fact, preferably if he can do a few more years in the hospital, just to gain the experience, so that he's confident enough to see patients.
Right.
So basically, in terms of qualifications, is that. But then we also have doctors who do extra qualifications, really a diploma course, something like occupational health and various other things, so that they can even specialize within family practice.
Yeah.
Or you'll have someone who does a course on diabetes because he wants to see more diabetics and be specialized in ensuring that if he sees a patient with that particular illness, he's able to give the best that he can.
Yeah. You talk about, qualifications and confidence and so on. If you look at a typical family practitioner versus a specialist, does it then mean that the specialist has a higher level of knowledge as compared to a family practitioner?
Well, like it was called in the past, a general practice. A family practitioner is someone who is quite knowledgeable in various aspects of patient care. So it's someone who would see, patients who have non-communicable diseases, as we're talking about the quadruple burden of disease. Yeah. So most of family practitioners will see most of those patients.
So he's a doctor that has a very broad knowledge on various...
of medicine. In actual fact, he's supposed to be the first port of call for any patient who's not feeling well, in that he'll be able to make a diagnosis. Yeah. And if he's unable to treat that patient, he can then now refer that patient to a specialist and to an appropriate specialist who will then be able to deal with that particular illness.
Dr. Marshall, is that your experience? In terms of the level of expertise required of general or family practitioners?
Yeah, my comment on that I think the level of expertise required of family practitioners is higher, if not the same, as specialists. It's a very different way of practicing medicine, and as Elijah has said, you have to have a broad range of skills. Right. You cannot focus on a specific area. Where in a specialist practice, there's a focus on a specific area, and even a focus in an area of an area, if you know what I mean, on a joint or so. It's actually a very challenging career.
Okay. All right. So what do we call a GP who works in the public sector? That and more after the break. Please don't go anywhere.
The city of Durban and its surroundings is one that is filled with history and cultural diversity.
Durban is a natural paradise known for its gorgeous coastline of sun-kissed beaches and subtropical climate.
Flea markets are essential to visit if you want to experience Durban's Afro-Oriental atmosphere.
The city of Durban is an elegant, mature and ambitious city. The vendors at the Vic offer a range of African and Oriental products, an eclectic mix that is hard to resist.
That's Kaleidoscope, Sundays at 5:30 p.m. CAT.
Morning Live sets the agenda for the day. We bring you the latest local and international news.
We are on the ball with all your sports activities and results.
We give you the latest business update.
We bring you the latest weather every time.
Watch Morning Live every weekday morning at 6 o'clock, bringing you everything you need to know before you go. Shap shap, tada.
Welcome
Welcome to Network, a technology news program that also discusses what's trending in social media in and around Africa. MTN has launched its new movie and television streaming service, Front Row. If it's trending, we will find it. That's Network with me, Spumelele Zondi, every Sunday at 7:30 p.m. only on the SABC News Channel.
District clinical specialist teams made up of 7 members are being set up in every health district in the country to improve the quality of healthcare workers in each district. We visit the team in Tshwane, which is one of the first teams to be set up.
I'm the team leader of the Tshwane District Clinical Specialist team. We are trying to reduce maternal and child mortality. So it means all the
team's role is to provide support for primary health workers and recommend improvements to be made to the health facilities. Reporting is made to the Department of Health and the district manager.
We also report back to each facility manager after we have been visiting a facility so that they know what the problems was and how they need to upgrade.
One of the ways the DCST assists healthcare workers is by running training courses and workshops.
We use the ESMO course to try and upgrade people's skills to reduce mortality. When you look at certain aspects of the mortality amongst women, in postpartum hemorrhage, for example, 80% of women that die because of substandard care. In other words, if they'd had proper care, they would have survived. In hypertension, which is the second most common obstetric cause of death, 60% die because of poor treatment or wrong treatment or incorrect treatment. ESMO is trying to correct this, and this is how we are trying to train people, upskill them, and enable them to perform better.
What we have is in Tshwane is a metropolitan area, also a big rural part attached to the metropolitan area.
The district is huge. There are 2.8 million people staying in this district of Tshwane, and we are 7 people trying to cover a big distance every day.
Thanks to technology, the DCST is able to support healthcare workers around Tshwane via SMS and MMS if they cannot be there in person.
We have a big vision for Tshwane to improve HIV and TB management for children. And we started in the year 2004 with the antiretroviral program. So you would think in the year 2013 we would have covered the needs in terms of the ARV program, but unfortunately that's not true at all. We currently, as a district, have about 6,000 children on the antiretroviral treatment program. One of our biggest problems in terms of the HIV issue in children is that we do not know where the children are who are HIV infected.
To deal with this challenge, the DCST implemented events in Tshwane District, where mothers and caregivers are invited to bring children for free screenings.
The Child Health Day at Stanza-Popapi was just one of these events that we will be having, is to identify children who are HIV infected. So we did a lot of HIV testing on that day, but in a non-stigmatizing way.
mama, hey Yahweh, mama.
And the fact that we had 577 children coming to that day just tells us that parents want to have these services for their children.
Hey Yahweh, mama.
Yeah, so sometimes you or your loved one visits a public clinic or hospital casualty and some doctor will consult you. Is that doctor the same as your family practitioner? Is he or she more qualified or better than your family practitioner? Well, let our guests clarify that and more. We joined back by Mr. Murawani, Chief Director, District Health Services in the Department of Health, and we still have Dr. Elijah Nkosi, who is a family practitioner himself. But I must add that he's got a few years of working in the public sector or running a hospital, one of the biggest hospitals in sub-Saharan Africa, Chris Hani Baragwanath Hospital. Now, Dr. Murawani, we just saw that clip on district DCST, district specialist teams.
Yes.
And the wonderful
clinical specialist teams.
District clinical specialist teams. And I'll just get this term right.
Yeah, that's right.
And in there, we had a family physician and we had a few other specialists. Can you let's just take it from there. That family physician, we've just learned that actually this is a specialist. Right? Now, earlier on, you said that GPs could actually also form part of this. Just take us through that.
Yeah, let me just draw the distinction between the two.
Yeah.
GPs would go to the clinics as in the old way of either them going there to support the main line of service delivery at that level.
Right.
But when we realized that we were not successful in turning the corner, particularly around the maternal and child health areas, the decision was then taken that we're going to introduce the district clinical specialist team as the third stream of the re-engineering of primary health care.
Okay.
So that the specialists then contribute to improvement of the clinical governance at that level.
Yeah.
Not to necessarily go and be the key drivers of service delivery at that level, but providing clinical governance, monitoring, making sure that quality assurance issues come into play, providing those kind of advanced skills, to those that are working on the ground.
Yeah.
And in that group, you then find a pediatrician is going to be there, a gynecologist is going to be there, an obstetrician is going to be there, and then the family physicians are going to be a part of that team.
Okay.
Then you've got advanced midwives as well in that area, and primary healthcare trained nurses.
Right.
So that does not replace the GP that would go to the clinic.
Okay.
The GP still goes to the clinic.
So what I hear you say is that the private, let's call it private GP or family practitioner, has some role to play in the private, in the primary healthcare, service delivery, as it were, because you are talking about private family practitioners coming in to deliver service in the clinics, right? Now, let's move away from that for a while. We'll come back to the issue of the family practitioner. Let's talk about what we call a medical officer, the doctor that you find working in a hospital casualty typically. Now, please take us through that type of doctor. I mean, what is his scope of service and how does it differ from the private family practitioner, for instance?
At the primary healthcare level? Or general?
Even in secondary, tertiary in a hospital, yeah?
You talk about those that are employed within the system and they work every day, they work in hospitals, and if the hospital's got enough, in the past what we would do, would even encourage them to do outreach, to leave the hospital and go and visit a few clinics in that area, so that they're able to deal with problems that are unnecessarily referred to hospitals and make sure that they attend to the patients at that level. Those are still there. They're part of the workforce of the Department of Health. So they continue providing that support. But because we also do not have many of them, and when they go to the clinics, there's nobody covering the work that they've got to be doing. We then started with GP contracting to say, can we then look at the general practitioners that are working in these areas that Dr. Gosi has explained, urban areas, the township, and say, can they use their time on a contracted basis to go and provide services in those clinics. In that way, that doctor that would then leave the OPD on Wednesday, Thursdays for 2 hours to go to the clinic does not have to do that, because there will be a GP who's contracted to do that work. So it's more a complementary work that they're bringing to the party. So that medical officer continues to do the work, but doesn't have to then move out, because then there will be a doctor. That was the plan of us having the GPs come into the clinics.
Yeah. Dr. Ngosi, you've had the best of both worlds, as it were.
Yeah.
You've worked as a medical officer in a public hospital.
Yeah.
What are the differences between, or perhaps you can give us your own experiences in terms of your time working as a medical officer in a hospital versus now working privately in your own rooms?
I mean, I worked as a medical officer at Natalspruit, I think for more than 3 years. Right. One can equate a medical officer with a family practitioner or GP. I mean, in that you see everyone who's coming in there. And then based on your assessment of what the condition is, you then would call for extra help or something like that. But in the medical officer setting where I worked, it was in a surgical unit. So one could even do operations, laparotomies or something like that, because with training, you're able to do that. So now coming to family practitioners, if I were to continue that way, or GPs or family practitioners, there is a wide array of skills that family practitioners have. Yeah. In a way, they can handle a number of illnesses, be it medical, pediatric, surgical. So you'll find a doctor who's equipped to do all of that in the practice. But coming to the point that you raise, where you have now GPs or family practitioners assisting in the clinics, it's something that we've always wanted to have. We did have a similar arrangement in Soweto, but somehow it could not proceed. Yeah. I mean, in that, in the early hours of the morning, a doctor might have 2 or 3 hours of service that you can provide to a local clinic and would then be able to assist with the backlogs in the clinics, with the bedding, I mean, because clinics are overburdened, and would then be able to assess those patients and treat them. Some of them might even be his patients who are unable to afford, paying for his services and go to the clinic, and you can even see them there and be able to treat them.
Are there issues with contracting private practitioners?
I don't know what issues, but let me tell you what the dynamics are. We send out we advertised, we sent out, we popularized this contracting, and I think we didn't attract as many as we would have wished to attract. The few that we attracted, were quite useful in that, they provided feedback on the kind of service that we're delivering, where there are gaps. They would straight away send either SMSs or give calls. Then that assisted in us closing those gaps that they identified. But as I said, the response hasn't been that great. We're standing at around 200 of them that we could recruit. And I'm sure with time we'll be able to do an assessment to check what could really be the major problem. But there are no major issues from our side. Maybe there could be issues from the GPs. That will be clear to hear that.
Are there any issues from
your side? The issues has largely been fees that are paid per hour for those services. And in addition, I've known cases where you find that payment is delayed for a month, 2 months, 3 months, or 4 months. So in a way, doctors would then be despondent and say, look, what's the point of working when I'm not being paid? But the issue is really around fees. If the fees were to be fairly reasonable, I think they would then be able to attract doctors into the public health care system. But
it sounds to me like these are issues that can easily be resolved. But in terms of the role that the private practitioners play in the public sector, at least that role is there. It's defined. There's value in that sort of partnership, isn't it?
Oh yes.
Well, let's leave it here for now, because we have to go for a break. Now, when you or your loved one falls ill, who should you think of consulting? Your GP? A specialist? What should inform your choice? We find out after the break. Please don't go anywhere.
Nelson Mandela, keeping a watch over a myriad of statues, from generals and presidents to literary figures and humanitarianists. More recently, those who fought for freedom.
So there's no need to destroy. If at the end of the day, the statue has to be removed from where it is, it will be removed.
President Jacob Zuma and his counterparts will witness the signing of a number of bilateral trade and investment agreements.
Campaigns to eradicate racial discrimination and hostility succeeded. The nation now rallies behind President Paul Kagame.
Catch all news locally and internationally. Tune into SABC, your #1 news channel. News at 8 from Monday to Sunday.
It is in your hands to make of our world a better one for all.
Welcome back. Now, should specialists like pediatricians be consulting children with minor ailments like cough, colds, or asthma? Or do family practitioners know less than the specialists on these conditions? Let's find out about this and more from our guests. We're joined back by Dr. Mike Marshall, General Manager, Provider Contracting at MedScheme. And of course, we still have Dr. Elijah Nkosi, a family practitioner himself. Now, perhaps let's start with you, Dr. Nkosi. I mean, we've gone through what a family practitioner is, the level of skill, and so on. But there is this problem. I don't know whether it's from your side as a family practitioner or it's from our members out there, our society out there, that this talk of, I have my own gynecologist, I have my own neurologist, I have my own physician, pediatrician, and so on. Is that necessary?
No. I mean, the answer is certainly no. A family practitioner is capable of treating most ailments. And in instances where he cannot, he's the appropriate person, he's the person who can refer you appropriately for secondary care. I mean, what we're speaking about now is really primary care issues. And secondly, I mean, if a patient has a medical scheme or something like that, and if they go directly to specialists, they would, deplete their benefits and would not have, enough money to see them through the whole year. I mean, in that you really would want to cover them for 12 months, not for a shorter period. Yeah. So it is important that they take care of those benefits by using them appropriately. So the family practitioner, I mean, as we're looking after the whole family, you want to be able to see those patients around November or December and be able to give them good treatment that you've been giving them throughout the year. So no patient should say, I've got my own gynae, I've got my own pediatrician. The first port of call in all instances, unless it's a life-threatening situation where, I mean, a person has to be rushed to the hospital, they have to go to their family practitioner.
Well, let's find out from the medical schemes. I mean, do you encourage that? Because you just pay these specialists for seeing, you know, minor ailments that could be seen by family practitioners?
Yeah, certainly, I mean, this is a problem in the private healthcare industry. I mean, I think there are many good things about the private healthcare industry, but one of the things not so good is the cost of it. And what you're describing now is something which causes fragmentation of care. And what we're looking to is actually coordinate care. And what we really would like to be encouraging more is that role in the family practitioner.
Yeah.
So
maybe let's talk about that coordination of care and how you envisage, you know, this happening.
Yeah. Well, maybe let me explain the problem. I mean, the problem is that a member may go to one GP, 3 or 4 GPs, directly to a specialist, to many specialists, and what that does is it fragments the information about that particular a member. And when we look at our data, we can see that those members for the same condition cost probably at least double the amount, and the reason is that there's nobody taking accountability for the overall care of the patient. So we're actually able to show quite clearly gaps in care. Things are not done for diabetics, it should be done. For hypertensives, it should be done. So what I think most medical aides should be doing, and I should be trying to encourage, is that role of the family practitioner as the primary coordinator of care, not restricting access to specialists. And I think that's often misunderstood. This kind of intervention is misunderstood as schemes trying to say, no, you can't go to a specialist. No, it's exactly the opposite. It's allowing access to specialists, but to the correct specialist and at the appropriate time. And that is something that really needs to be looked at and improved, I think, in the private healthcare sector.
Yeah. Well, Dr. Nkosi, I mean, these patients sometimes would come to you to say, you know, I tried to arrange an appointment with my gynecologist, and I was told that, no, I have to come with a letter from my GP. So I'm just here to pick up this letter so I can go and see my a gynecologist. How often do you see such cases, and how do you deal with them?
Yeah, it's unfortunate that we do see, I mean, those cases. But the way we deal with them is that, in a way, you know, I would sit that patient down, talk to her, and then explain that, you know, you first need to be seen by a family practitioner. And more often than not, you'll find that it's a condition that just can be treated, and it's not necessary to do that. I mean, in terms of providing those services, I mean, like you're saying, family practitioners can do pap smears, they can do minor surgical procedures. So in actual fact, ideally, everyone should go to their family practitioner who will then coordinate care. I mean, like Dr. Mike Marshall was saying, in that he knows that patient quite well. He knows even the family. After assessing the patient, he'll be able to say, look, I can manage this condition. Let's give it a week or two. If you're not improving, would then refer you to a specialist. But more often than not, in a few days, I mean, that patient is back on his or her feet and they're okay. And in a way, it prevents, you know, having gone directly to a specialist and incurring a lot of tests and a lot of unnecessary services that could have been prevented.
Yeah. Perhaps, I mean, if you could draw an analogy, this we also see in the public sector where, I guess, you know, when you have a child that's not well and you go to a clinic and your child is seen by a nurse who's competent enough to deal with whatever your child might be having, perhaps people don't see that positively. They see this as, you know, my child getting inferior services. Your comment on that?
Yeah, I think the challenge around that, it's really community education.
Yeah.
Or patient education, but largely the community, where they need to understand that even if it's a nurse practitioner, he'll be able to treat simple flus. I mean, they take temperature and examine the patient. If it's a simple flu, a nurse practitioner can do that. And equally, I mean, for most of the illnesses, a family practitioner will be able to deal with those illnesses. There will be those few cases that would require specialist referral.
Okay, let's find out from the medical schemes now. In terms of specialists that, you know, consult members of the public for really minor stuff that, you know, any family practitioner can deal with, how do you deal with claims that you receive for just once-off consultations from specialists for conditions that could easily have been treated by family practitioners?
Well, yeah, that very much depends on the scheme and their rules. So some schemes, many schemes still, pay for direct access to specialists.
Yeah.
A lot of the schemes now are starting to put in rules that basically say, look, before you go and see a specialist, you need to go and see a GP. And if you don't do that, there might be a co-payment. It might not be funded at all. So they are trying to enforce this. Because after all, I mean, healthcare is a team sport, and one does need someone to coordinate the care. But at the end of the day, it is a medical aid. People buy product, and one has got to sort of balance all of this.
Yeah. But I think the message in all of this is that the family practitioner is well placed to deal with any sort of condition that emanates and should be the first point of contact before thinking of any specialist for that matter. Well, gentlemen, unfortunately, we've run out of time. It's been a very informative discussion. I certainly enjoyed it. And thank you very much for your contribution.
Thank you.
That's Dr. Mike Marshall, General Manager, Provider Contracting from MedScheme, and Dr. Elijah Nkosi, a family practitioner based in Soweto in Johannesburg.
Yeah, in Soweto.
All right. All right. It's on that note that we've come to the end of our show today, folk. Your views and comments, again, extremely valuable to us. Please share them with us on our Facebook page, SABC Health Talk, and follow us on Twitter at SABC Health Talk, or drop us an email, SABC Health Talk. And again, join us next week on SABC News. You can watch repeat of this show, by the way, at 2 p.m. and at 10 p.m. And if you missed any of our previous shows, you can get them on the YouTube channel. I'm Dr. Silo Mudau. Thank you very much for watching. Take care.